Today the topic is major depressive episode. How do we choose the antidepressant? I didn't very consciously, I didn't put there how do we choose the antidepressant or a antidepressant or an antidepressant. I just left it like that. How do we choose antidepressant? Because that itself is going to be a major issue. Today, actually, there are about 55 questions with me, which has been sent by some of you, the delegates who are pre-registered for this. There is some overlap in some of the questions. And as you all know very well, it's not that I can answer all the questions, but we'll make an attempt. And then some of them are very, very interesting for discussion. And based on that, I pulled out some of the slides also so that you can have a look at it and then decide for yourself. So today, what I'll do is, maybe just give me about 15-20 minutes. Very briefly, I will run through the concept once again about the major depressive episode, and then, which is my favorite thing about prognosis being good, recovery being the so-called normal. I'll go with that. And then we'll go to the different questions. There are so many questions. Let us see what we can discuss about it. When we discuss about these questions, I think you're free to keep sending your chart, some of the questions. I will leave that open so that your opinion also, maybe some of the questions, I won't be able to answer. From some audience, if the answer comes, I think we will all share with this. But first 10-15 minutes, give me to some time to present my slides. So this is what today's topic is. Right. Straight away to go to this. These are the questions. Some of you can quickly run through this, and I'll keep the slide for a minute so that some of you who have not asked these questions also, maybe you may find these interesting questions in this, and some of you may know better answer than me for this. Later when we discuss, you can share while we are discussing about it. About 20 questions are on this, on a different topics. It is, please go through that, sir, and then maybe some of them will take it up. Actually, something like bupropion, I pulled out 1 or 2 slides. And study, there was some request about the topic. We have discussed study 2-3 times. That is why I am not bringing those topic again, because for quite a few of you, it can be a repetition and then can be boring about it. But 2-3, delegates, and then some of you asked for it. What about this study? Okay? So these are the first 20 questions. Here, I think there is one question from, this has actually come from Dr. Grace from Nairobi. Would wish we get more on different mental health conditions and their management. Chintan, are you listening to this? Because if you ask me, my competence is very much limited to what it mostly, let me put it very clear. I am talking to you and sharing with you only my clinical experience, related experience I'm sharing with you. And mostly with the mood disorders. Other psychiatric conditions, I am really not that competent to talk about. I think Chintan can look forward to I can take up some of the other speakers for this, because would like to know more about anxiety disorders and panic disorders, which are very, very important. Some other speaker can take it up. Both these requests has come from Nairobi. I think it's really good. We need to can take up other topics also for discussion. These are the other 20 questions. What I did is that this time I thought, let us discuss in as far as possible in detail these questions. And when I looked at these questions, there were some relevant, either an article or some slide which I had I pulled out and said that, okay, this seems to be this. Whether from this, what is your kind of an inference? Like that also, I am going to get some slides out of this. People have asked at the very young age, what is the most, the safest antidepressant? And then there is one question about when do we use MAO inhibitors? Let me put it straight away, sir, here. I do not have any experience with MAO inhibitors. There's only one, that REMA, moclobemide was there, but very few patients we used. Right now there is tunnelcepramide, but to tell you frankly, I have not used it at obvious reasons. You know that now, there are so many of this. So when the case of resistant depression comes, there is an option for this, but you have to take all the precautions. But beyond that, my experience is not really good in this. Somebody commented that how do we choose an antidepressant? By systematically trying each option? Definitely. But you need to have something first. Where do we start? That's going to be like that. These are 43 questions. And then, right, another very good question. This is, how do we manage cyclothymia? Do we manage this? This somehow I did not actually understand. This has come from Kisumu, Dr. Tom. What time in EAT? I don't know whether if any of you know about this, please know, like during discussion we can talk about it. EAT, I am not very sure what exactly it was about. So, is there a latest clinical algorithm for the management of bipolar disorders? This has again come from Dr. Sheila, Jambonga City. See, the latest I know to my knowledge is CanMat. There are almost about 23 algorithms or more than that, but of all the things, the one algorithm, this one which constantly updates very regularly, very frequently, every 2-3 years is CanMat. And this time CanMat 2018 stands out very specifically because it has made a very broad changes. Number one is that it removed the term mood stabilizer. Second is hierarchy model. 1, 2, 3, 4, 5. First option, second option, like that it has given only, I think, as far as I know, CanMat is the only algorithm which has given that. CanMat 2018, it's hardly 2018 March it has been released, it's 2 years. So these questions will come back. Now, going to the topic of it, I think before we go to the topic of how do we choose antidepressant, once again, let us talk about major depressive disorder or major depressive episode. Very briefly, I won't take much time. This is a 1976 paper. Kendall, I think some of the seniors know that. I think if I remember correct, he was the author of Companion to Psychiatry, the book. One of the very, very big names in mood disorders, especially depression. Kendall, Classification of Depressions, Review of Contemporary Confusion, British Journal of Psychiatry, 1976. He made this statement. Last 50 years, particularly in the last 20, innumerable different classifications of depressive illness have been proposed, and several disputes are smoldering away between the protagonists of rival schools. And at that, the same article, he has predicted that for a long time to come, it is only this classification which is going to be standing there, and it's only valid classification, endogenous, exogenous. This is what Kendall told in 1976. But within 4 years, DSM-3 has come out with a drastic, it's a completely revolutionary change in the concept of depression, introducing major depressive disorder. This is DSM-3, I think some of you know that, most of you know that it's revolutionary in that for the first time, the classificatory system broke away from the psychoanalytical school and the symptom clusters. And the most important thing is neutral with respect to the etiology. Endogenous, exogenous, it has respect to the endogenous means more of biological, endo, within, exo, coming from outside, reactive. So this has done away with this, neutral with respect to the etiological cause. This has got a lot of clinical importance because youngsters may not know. I did talk about it some time back, and then some of us now, who are now seniors, we know that As students, we were not allowed to give antidepressants to the, if you make a diagnosis of exogenous depression, reactive depression, neurotic depression, which is all the same, you cannot give antidepressants. You can give antidepressants only for this. So all this group, they were not getting the benefit of antidepressant at all. Very strictly that no kind of dissociation was there only for this. So this has done away with it, neutral with respect to the etiological cause. Some of you may say that how can etiology is the most important thing, that's what RDoC is talking about and all, but for the sake of it, I just put this point. 50s, not very long back, cancer research were of three groups. Somebody said cancer is due secondary to viral infection. Somebody said cancer is secondary to external chemicals. Somebody said it's a genetic mutation. Maybe all three are together there in the, like an ultimately in the development of cancer. But if you look at the etiology, sometimes this kind of a classification may happen, and patient may not get the correct treatment. And then these are very, very important points. Again and again, I tell you that natural course of mood disorder, recovery is a rule. And this one, somebody asked a question also, are there clinical biomarkers? We don't have biomarkers, endophenotypes as in today, but I'll consider family history. When the presentation is vague, major depressive disorder, when the clinical presentation cross-sectionally is not very clear, family history, past episodes come to your rescue excellently. These two things I consider as a clinical biomarkers. So this is what the evolution of major depressive episode, major depressive disorder. Why I'm talking about this is that before we think about which antidepressant to choose, we have to look at what is the condition we are giving antidepressant, and also what are our what is the natural course of it, and what is the recovery metrics we are looking at when you look at the outcomes. Sir, all of you are very senior people here. I'm going to present a list of presentations. The reason why I said very clearly is that sometimes the clinical presentation is not clear, but it is that this is not just the case even in psychiatry. Even today, with all the investigations, including the PET scans and then including the histopathology with there, internal medicine people still talk about PUO. They still have the problem with the diagnosis. It's not only we, in spite of all the technological advancement, they still have the problem. So we have it more. So that is why these things are very, very important sometimes. Maybe later we can also discuss. The 64-year-old who is not sleeping and eating for the last 3 weeks, possibly depressed, possibly. I'm not saying that definitely, possibly. But if this man had 2-3 similar episodes in the past where he has recovered from, most likely, that is what the clinical biomarker is helping me. But otherwise, it could be anything. It could be anything. A 45-year-old homemaker who cries and cannot cope at home, possibly it could be mother-in-law, but still it could be major depressive disorder. 39-year-old persistent fear of having cancer for the last 2 months. It could be a kind of a phobic symptom or illness anxiety, but possibly it's an underlying depression, major depressive disorder. Possibly, sir. The variety of ways major depressive disorder can manifest, and then the different age groups, all these age groups. 35-year-old executive who is fatigued all the time, there's no particular reason. All the investigations are normal. He went and did the whole lot of battery done, including thyroid, like a CBPs, everything is normal. But he's most of the time he's fatigued. By evening or morning, he doesn't feel like going to work and he's fatigued. Possibility of depression. 20-year-old newlywed always accused by in-laws being lazy. This girl is not working and they say you're lazy. But possibly this girl could be suffering from depression. Possibilities, and only. But where we have to, when other investigations and other systemic examination becomes completely normal, and this kind of symptom, we have to raise the red flag of possibility of depressive disorder. 20-year-old slashing his wrist, failure in love, possible, very possible. This has become very, very common thing of late. We are seeing that. 18-year-old become a recluse, adolescent, teenager. He doesn't give any reason, but he's not talking. He's locking himself inside the room, and parents are extremely worried. Possibility of that. Sudden loss of interest. This could be 10-year-old girl with a school phobia every second year. past episodes. She is otherwise a brilliant girl. 2, 3 years back, or 3, 4 years back, she had one. 2 years back, one again coming back, suddenly saying that I don't want to go to school. What is the reason? I don't know. I don't want to go to school. So all this starting from 65%, all this could be possibly depression. No, like that. See, some of you may ask that, like that, if you stretch, there could be a lot of things which could be possibly. But all these patients, when you rule out all the so-called organic or physical factors, still they are having a significant problem with this. We have to think about the possibility of major depressive disorder. When we are not very sure, we have to look at the past episodes. When again, if there is some information, we have to look at the family history, which is going to give us a lot of clues, which I say clinical biomarkers. And these are the patients where you can choose an antidepressant effectively, and all these people can get very effectively treated by giving antidepressant. Possibility. That is why I put this slide, and then we can discuss later. These are all the possibilities and different age groups, different kind of presentations depression can present. Right, escitalopram, sertraline, the two drugs. I think I showed you this one also before. Again, I am repeating this. Only one reason. Do you believe this slide? I think last time also I asked the same thing. Simple major depressive disorder. Let's forget about 2 years, 3 years, 4 years, 6 years. 1/3 of patients who are diagnosed as major depressive disorder, they remain recovered, no episode. You have treated them episode, 1/3 of them remain completely all right. There's no episode. He's forgot psychiatry, forgot psychiatry scene, forgot antidepressant, he's all right. Great. That is what the prognosis of MDD. And then this 34%, they had a recurrence, but again, recurrence also recovered. Right? But see, like we can't say that sinusitis you have, you recover. Again, you can have another episodes of flu or sinusitis next year, and then you recover again. Good prognosis. 28%, there's a recurrence. Out of these recurrence episodes, at least one episode is chronic, not all. This is this, and only 4% are chronic, which are beyond till from day one to till now continuously, which you call it as a persistent depressive disorder. Previously, we used to call them dysthymia or whatever it is. This is what it is. This background, we have to look at how do we administer antidepressant. This again is the slide I have shown you before, right? I think, sir, most of you agree with that. This is a euthymic phase, depression, and then this what is remission. Remission sustained for 8 to 12 weeks is recovery, and then this you call it as relapse, and then recurrence. This has been taken away in 2018 CanMat. That's a different thing. This is the natural course. Let me again put it: a depression patient came with MDD. If you don't touch him, if you don't treat him, he will come out of it again after some time. How much time, I do not know, but he has to recover. That is what the natural course. Our job is to cut short this into this so that morbidity and suicidal mortality is curtailed, prevented. That is what our job as physicians or now doctors, what we do is that pre-recovery phase, do this beforehand. This is what natural course. What we do is facilitating the natural course, thereby minimize the morbidity and preventing mortality in this period. That is what we are supposed to be doing. Now, I think last time I talked about, now I'm going to talk about this period. This period is very, very important for us. All our clinical skills, therapeutic skills, psychopharmacotherapeutic skills, psychotherapeutic skills are to cut short this. Now look at this red arrow here. After tentative 16 weeks, aerobic exercises, St. John's wort are equal in effectiveness with imipramine escitalopram. You leave the patient like that, you compare escitalopram and then St. John's wort. At the end of 16 weeks, both are same. Ashwagandha and escitalopram are same because there's a natural course recovery. So that is why sometimes you get this, all these are very effective. You get this, the same thing. If you look at here, there'll be a marked difference between your antidepressant and then exercises and then all that. At this point of time, both are same. This is a very, very important point we all have to remember. Sometimes we wonder, this is what the natural course is about. Right, therapeutic goals, sir. I think recovery and then preventing suicidal mortality, preventing future episodes is one thing. I think I would like to hear from you how effectively we can prevent the future episodes in simple recurrent episode disorder. And any treatment we select, whether it is whatever is the treatment, it has to satisfy this. I think all of us know that. Effective, it has to be applicable. What is the scalability, tolerability, safety, replicable, afford? Any treatment for any medical disorder has to satisfy this. If it does not satisfy this, it is not going to. At some point of time, when people developed MI, when they had to go for coronary graft, CABG, people used to go to Houston to get the surgery done. Effective, but it is not. But now, every street corner you do CABG, that is why it has become like that. 1.5 lakh rupees you do this, accessible. Every town also they can do that. 1.5 lakh rupees you can do that. That is where CABG. If CABG was not possible in these situations, it will not be an effective like treatment, therapeutic measure any place. So this becomes very, very important. Why I'm saying very specifically is that antidepressants, it is what is important. I think we need to look at this advantage of antidepressants. Yeah, right. This slide I'll come back again. I'm just showing you. This is one of the latest, I think, 2018 Cipriani's meta-analysis, where he showed that like effectiveness of efficacy of antidepressants. This is a placebo. So all the antidepressants are effective. All what are all listed here are effective according to this meta-analysis. And then equally important is not the efficacy, but also tolerability, acceptability, which is very, very important. So when you come to this, see, if you see this, all the drugs are effective. Last time I told that when a DPM first year student comes and asks me, doctor, I'll start reboxetine and not escitalopram, I just cannot open my mouth because both are effective according to Cipriani. No doubt about it, about the evidence-based medicine. But when I look at here, I can tell this boy, look, reboxetine acceptability is very, very low. See, it favors placebo, forest graph. It favors active drug. So you cannot. So this also becomes very, very important. We all know that we select a drug not just by efficacy, but also by the side effects and then tolerability profile. That's why I just showed this. This tolerability thing is very, very important because one is our treatments are a little bit longer treatments, and we always have the problem of complaints. Complaints, concordance, adherence is always a problem in psychiatric pharmacotherapy. That is why this becomes very, very important. I'll just run through maybe next 5 minutes some of the factors which affect adherence. This is really surprising. This is amazing. This is. For Hippocrates in 4th century BC, he made this statement. This is not yesterday you and me talking about keep watch, which often make them lie. He was very, very rude actually when he told, make them lie about taking of things prescribed. So he was talking about non-compliance in whatever may be the treatment method which has been prescribed in 4th century BC. The same statement once again has been talked about by 19th century Robert Koch. Tuberculosis, you know this man. I'll come to this tuberculosis model maybe later. This is what it is. Right? If somebody asks me, non-adherence is in human genes. Adam and Eve, they were told not to touch the apple. They did not adhere to that, and then the fall of man and the expulsion from the Garden of Eden, that's because of non-adherence to what God has told them, don't touch the apple. They did not adhere to that. I think this is the first example of non-adherence. Depression, if you take, 10% never follow complaints, but this is what I was worried about. Discontinue first week, 16%, second week, 41%. By third week, 59% of people. It takes 3 weeks for our antidepressant to show the effect, but by the time 60% of the people are all dropped out. I thought it's okay, 1981 when SSRIs were not there, it's only tricyclics. But even in 97, it's almost a similar kind of 30% of patients, 40 to 60% by 3 months. So this is another very important crucial thing when we select an antidepressant. That is why I mentioned this. This is a funny thing. Have a look at this. This is a slide. I don't exactly get the reference. This is when you prescribe, a patient comes to your clinic, you prescribe the drug 100%. They go out, they buy from the pharmacy, that's it. 12%, don't take it. They buy after that, 12, like, yeah, 12% don't even take buy the medicines. Those who take buy the medicines are only 88%. And out of this, 12%, they buy the medicines, take it and dump it in their, like in a cupboard, they don't take it. And finally, it's a 47%. This is an interesting slide. This is, I think, 1996 or something. If I would be suffering from schizophrenia, I would have been taking my maintenance dose. Even psychiatrists told that only 71% of psychiatrists told that 29% of psychiatrists told that I will not take maintenance dose of schizophrenia, maintenance dose for schizophrenia. I don't know what is the reason. Even the other medical persons, so less than 50% said we'll take it. Right. What are the factors? I'll quickly go through that before going to the question. Illness-related, physician, treatment, patient, psychosocial environment, patient. These are all the factors which we have to keep in mind. Right, illness related, we have the problem is we don't have the confirming evidence like diabetes. One of the most important thing is depressed patient has got a significant negative cognition of hopeless, helpless, inferiority, negative, suicidal thing. So in that kind of a state, looking for some kind of a positive hope in taking antidepressants and getting better is going to be very difficult. Psychopharmacological Calvinism, because anything you take, any medication you take which improves mood should not be taken. Right. Physician related, you have to believe that the diagnosis of MDD is valid. And I think this is a very important statement. Negative therapeutic alliance is the single most negative factor for non-compliance. Single most. So you have to be very careful. And this I say that. You agree with him, but some element of, I think all of you remember Gandhigiri? It helps. Nowadays, in the days of Google, everybody thinks he knows everything. So you have to put it in such a way that you know slightly better. This is what I call is a benign dictatorship in Gandhigiri. Helps a lot in conveying that you are slightly better in your knowledge and wisdom compared to the patient, and then Google this thing in convincing the patient he has to take. But therapeutic alliance is a very important thing. People say that there is CBT. Why should I take medicines? Study said only 30% of people are improving. Why should I take? Delayed onset is the problem. I think, yeah, here I think we should talk about nocebo effect. When you give the medicine for improvement, they first come out with saying that side effects. It's because mostly the moment you prescribe an antidepressant, I think some time back I told you, I gave a 5 milligrams of escitalopram to one of the very senior doctors. The next day morning, he called me saying that after taking this tablet, I'm getting an intense suicidal ideation. It's because of the drug what you have given. Quite a few times we see that after prescribed the drug, the very next day morning, people come and told me, doctor, I'm having a significant sexual problem, erectile dysfunction. It's hardly 5 milligrams or less than that. It's one day. It's mostly because of more than actual experience. It's a fear of that, and also the stigma and all. We all know that these are some of the factors which are like the reasons why people do not take drugs, and this is non-adherence. Why I talked about these points, these 15 minutes, is number one is that about the diagnosis of MDD, the prognosis being good, and then you have a clinical biomarkers and the age range and the different varieties of clinical presentation where they can present, and some of the reasons why tolerability and acceptability is very important. That's where we, like in before you choose an antidepressant, which is going to be the most important thing. Now, let us look at now some of the questions and then discuss about this. The very first question is that I think some of you remember that what are the factors one has to look into while choosing an antidepressant? I think it's a very relevant question for this topic. What are the factors you have to look into while choosing an antidepressant? let me go back to that again there. Right. After seeing this question, I prepared this. All these factors. You have to look at effectiveness. And then sometime back, we were looking at whether it is specifically serotonergic mechanism, norepinephrine mechanism, or dopaminergic. People are saying that serotonergic system more of your appetite, sexual dysfunction, noradrenergic effect is merely energy, dopamine is hedonic. And then long time back, we used to give the drugs based on MHPG secretors and MHPG non-secretors. This is almost 40 years back I was talking about. That time, imipramine is supposed to be more towards noradrenergic mechanism of action. Amitriptyline is more towards serotonergic system. So this MHP is noradrenergic metabolite. So based on this, we were dividing that, but these are all really did not help. Insulin hyperactivity, I'll come to that. Pharmacogenomics, somebody also asked me, I do not have an answer regarding that, but as on today, whether it's in India or outside, there is nothing like a specific pharmacogenomic test based on which you can give somebody a particular antidepressant. These are very important for me. If somebody has got a significant anxiety, I think I'll make a small change in either an antidepressant and add clonazepam. OC features are very, very important. If somebody has got a significant OC features, either as a part of depression or a premorbid thing, my dose of antidepressant will go up significantly. So these are all the factors. What are the factors one has to look into? I have to look at this. I'll just show you this slide. Maybe insular hyperactivity. I think, let me see whether I can show you this slide study. Clearly, see that this is a CT scan picture. If a patient's pre-treatment resting brain activity was low, insula, right-sided insula, anterior insula, if pre-treatment, if it is hyperactive, they respond better to escitalopram. If it is hypoactive, they respond better to CBT. This is one of the conclusions in 2013. It looked wonderful. Like we have got a biomarker. You do a scans, fMRI, and see that right side insula, if it is an anterior part, if it is hyperactive in the resting state, this patient with MDD is going to respond better to escitalopram. If it is hypoactive, he responds better to CBT. This is one of the findings. Helen Mayberg, I think most of you have heard, has done a lot of work, especially about this, and also deep brain stimulation for resistant depression, where she told that the anterior genu of anterior cingulate gyrus stimulation helps a lot in coming out of depression, because this is what insular hyperactivity. I showed you this, and I'll also show you. Somebody asked about the pharmacogenomics. I cannot really make out anything on that. Let me show you that. There are so many of those factors. Right. Depressive disorder. I can only show you this slide if you ask me what is the pharmacogenomics based on antidepressant. I cannot really talk about it, because as on today, don't do that. And then this is what the slide I can show it. There's one more slide also where biomarkers. This, if you look at this, this is supposed to be slight hyperactivity of the mainly amygdala here. And this is anterior cingulate gyrus, inferior part of it. This, ventral anterior cingulate gyrus. This hyperactivity is supposed to be, that's what they say, that from this circles and black arrows indicate brain regions most likely to be predictive of treatment response. Most likely to be. So these are all in the initial, still in the research phase, whether it is pharmacogenomics or an endophenotypes or any specific thing. We do not have anything very specific on that as in today. So I'll go back to my slide, and what are the different factors. We'll come to it again. To look at, listed out some of this. Maybe this can come later in the discussion part. This is very, very important to me. This is the only reason I don't prescribe fluoxetine. Otherwise, fluoxetine I would have been. This is again very, very important to me. This is one of the safest reason why SSRIs are more commonly prescribed. This is again dose titration, once daily, monotherapy. Okay, all these things are very important. These are all the different factors which I look at. Side effects, short term, long term, whether it is a significant side effect. Sedation, if it is significant sedation, I will not prefer the drug. Withdrawal syndrome is very, very important. The reason why withdrawal syndrome is important is that most of the times our people think that our drugs are psychiatric drugs or psychotropic drugs are addicting. So immediately when he stops the drug, when he finds a significant withdrawal symptoms, patients and caregivers, most of them are extremely scared that we are getting addicted to that. That's a problem with both paroxetine and then the other drug, venlafaxine, desvenlafaxine and venlafaxine. Because these are cognitive impairment. This is something where people talk about it, but I do not have much of an experience. Vortioxetine is supposed to be one drug which does not impair the cognition, but I don't have much experience. This is been described. I'll come to it again. I want you to just see this pulmonary hypertension in children, fetus. When you give for the pregnancy, teratogenic, fluoxetine can we try 1 week? These are the things I was looking at. Now, what is the drug of choice? Somebody asked. At this point, I think I'll go for the chart also. Like if there's anything, what is the drug? For me, the drug of choice is escitalopram. There's no doubt about it. Because if you ask me why escitalopram, doctors SSRIs is the first drug. Among SSRIs, let me take another minute. SSRIs is the first line choice all over the world. Textbooks and everything says that. Now we have 5 SSRIs: escitalopram, sertraline, fluoxamine, paroxetine, and then fluoxetine. Right? First drug which came into market was fluoxetine. I was writing fluoxetine very well. One of the major positive thing about fluoxetine is that it is a non-sedating drug, and second most important thing is it's got a long half-life. You can give it once in 3 days. But my major worry with that was drug-drug interactions, which are sometimes it can be very disturbing. I'll give you a clinical example. Suppose there is a patient who is well hypertensive or diabetes, very well controlled on the drugs by another physician. He comes to you with a major depressive disorder. You start the patient on fluoxetine. Cytochrome P450 interactions can increase the antihypertensive, antidiabetic drug blood levels, and there can be a sudden drop. Either hypoglycemia or hypertension can happen. It happened to my patients. And that is the reason I don't use it. Right. Fluoxamine. Initially, when it came, it was a drug which has to be given twice a day out. Fluoxamine produces significant gastrointestinal side effects. That is another reason why I don't. The clinical efficacy of fluoxamine for antidepressant, I do not have much of a convincing experience with that. I did try it quite a bit. Paroxetine. Paroxetine is again a good drug, SSRI, no problem. Especially if there is significant anxiety, it helps. If there is a sleep disturbance, it helps without clonazepam. But paroxetine, the sexual side effects are significantly high, especially retarded ejaculation is very high with that, and withdrawal symptoms are very high. That is why I don't use much. So what am I left with? Escitalopram and sertraline. Out of these 2 drugs, both are the advantages, not very sedating, effective antidepressants, and then well tolerated. Titration is easy. That is, drug-drug interactions are virtually nil. I showed you one slide, a 10-year-old child, but for sedation. If it is giving sedation, I will not give. I will prefer fluoxetine. A 65-year-old man who has got diabetes, hypertension, is on statins and then aspirin and then a lot of other drugs. I don't even blink to write escitalopram or sertraline. That is a safety profile I have. And overdoses, it's no problem. Withdrawal syndrome, it's not. That is the reason why I prefer escitalopram. And then it is working good for me. It has got weight gain, it has got sexual, all those things are there, but comparatively it is that. That is why if somebody asks, what is the drug of choice? For me, it is escitalopram. And right, here there's one question. Is natural recovery from exo and endotypes both a rule even when exo causes persist? Exactly, that is the reason that the so-called exo causes, how far they are really causative rather than maybe just a tip, like the last straw. That is something which we have to see. When we talk about major depressive disorder, one of the criticisms on psychiatrists is that you people brand normal sadness as MDD and treat that. I completely don't agree. If you look at simple DSM-5 criteria, it has to be most of the time in the day, most of the day in the week, at least for 2 weeks. It doesn't happen in simple routine sadness and reactivity. Late insomnia doesn't happen. Diurnal variation doesn't happen. Psychosis does not happen. Seasonal does not happen. Postpartum depression. Now, this is a chunk of MDDs. Maybe there is normal sadness. So that is how I look at, nothing more. Google doctor is probably going to rule psychiatry. We may have to live with this. There's a problem which we have to suffer. What about treatment of why people are behind in psychiatry? Google doctor, yeah. See, I think we also discussed 20 years back, 30 years back, when somebody comes and said that, I think most of the seniors said that we almost tell the patient, shut up. You don't know. I know everything. Don't talk. Take this. It went. But now it's not going. What are the reasons it's not going? So that is why I put it as Gandhigiri. When I say dictatorship, in the sense, on the lighter side, I know everything, you have to listen to me. Ultimately, the patient has to listen to the doctor because you have a phenomenal medical knowledge. Just by Googling something, if even Google, you have all the formula even to make a nuclear bomb. That doesn't make that every one of us are going to make that. So that is where you have to somehow convince that. I think this point, Dr. Murali, a senior person, he asked that here, I think last time I asked, maybe I'll again repeat this. Yes, it's important, but still, sir, do you say that FDA still has to maintain a black box warning for SSRIs? That the risk of the suicidality increases in the age group. Last time I showed you slide, below the age of 24, suicidality increases. The FDA black box warning is there. What is the purpose it is serving?
But unfortunately, all these warnings are not being looked at by at least a large number of psychiatrists. I have to tell you that, because what happens is that with the SSRIs, the response is so good, the side effects are so low, and we tend to prescribe keeping on. And please remember, it is not a psychiatrist who are the largest prescribers of SSRIs. Yes. It is the general physician, neurologist.
Yes.
For every program, they prescribe.
Yes, exactly. Exactly. This is where it's a fact. Yes, we have to know the facts, but ultimately for the fact, is it doing more harm or is it helpful? Don't you think we all have to look at it? It's like one journalist saying that it has happened, I am reporting. And some responsibility has to be.
Can I tell my opinion? I will tell you, most of the neurologists do not go beyond 20 milligrams of fluoxetine.
I'll be very happy, sir.
And they, moment the patient do not respond, they refer to a psychiatrist to have an opinion. And you realize that somebody has not been treated properly for such a long time. And if you really look at it, our recovery rate is much, much better than lot of other conditions in medicine.
Yes.
And people do not realize it. See, for example, a patient with depression comes and tells you that I want a recovery in 2 weeks' time. I used to tell them that next to impossible. I cannot offer you a 2 weeks recovery. There is nothing like a course of antidepressants like antibiotics. It's a process which goes on depending on the individual, personal history, family history, number of episodes. All these things we have to take into consideration before prescribing anything. And that's what we have to look at it. So thank you.
Exactly. Those points very clear. But at the same time, when like I think last time I was asking, do we convey them that there is going to be a recovery from this episode? That is what is most important. That carry. That's where I said that the
Yes.
Gandhi, nudging, all those things. But we have to. Last time I think I was the question which I put up, bipolar disorder, any episode, this.
Uh,
I'm happy that 60% told that it is now like working so good.
if,
That
if
is
you
what,
don't if you don't mind, I can answer one more point on this.
yeah.
Bipolar disorder also recovers with episodes, but there is a disability occurring in all these patients over a period of time. That we have to look at it.
Which,
Thank you.
yes, sir, but which may be completely. Some patients it's always there, but majority maybe I don't agree with that. Like it depends on so many other factors, but it is from the episode symptomatic recovery is there. Let's see that. Let's go to the next question. Uh, Drug of choice for psychotic depression. Uh, I treat with SSRIs only, but antipsychotic has to be added. There's no doubt about that part of it. Absolutely, there's no doubt. And let me go to the other questions before I know I can answer these questions. How to, curious to know update. Okay, currently study again and again. People are asking about study. Pharmacogenomics, I tried to answer that. Combined drug therapy is more beneficial than single drug therapy for depression. So let me tell you here. As a rule, I say that monotherapy. Start with monotherapy. I am not going to agree with whatever you say to starting a patient and polypharmacy. This is one of the main reasons why I am so against bipolar disorder mood stabilization. Is that the only reason? We have no business to start on two antidepressant to start with. One you start, you give, like if the patient is having a thyroid problem, you give for sleep, add benzodiazepines or zolpidem. There's no problem at all. But that is something for a short time. So combination therapy later, not in the initial phase, sir. Very definitely. Antidepressant and bupropion and vilazodone. Right. I think that is why I pulled out one paper. I'll just show you. I'll share my screen again and I'll come to that. It is not that one paper is going to make all the difference. I'm not saying that. No. It's not that just one paper you can come to conclusions. But bupropion is very important to me because that was a drug tried by Step BD. And based on this drug and paroxetine, they said that antidepressants are not useful in management of bipolar depression. Please have a look at this slide, sir. I think very pointed question somebody asked me. What about bupropion and vilazodone? Look at this, sir. 2018 meta-analysis showed that weak evidence supporting use of bupropion. This is 2018 Journal of Affective Disorders. Efficacy varied strongly across antidepressants. I think we are right. We have been told that all are equivalent. Here, see that all tested drugs, whatever this meta-analysis has tested, except for bupropion, showed strong evidence for their efficacy. That means clearly this particular meta-analysis says that bupropion is not a very effective antidepressant. Little evidence that was available showed that bupropion has got a weak antidepressant effect. Right? Most of the trials which compared bupropion to other drugs for depression showed similar effectiveness, but this finding is based on, in part, on low quality evidence. I agree. Some of you made straight away question based on one paper, one meta-analysis. I'm not coming to conclusions. There is a question, I showed you this data. We have to give some importance to this also. And this is the most important thing. I was looking through that, the top 200 prescribed medication in US, top 200, looking at the list. I got this data recently. 2017, 50 million prescriptions for escitalopram, half the number for bupropion. And here, this meta-analysis says that bupropion is a very, very weak antidepressant. Why do you write that such a weak antidepressant? But theoretically, this is an excellent antidepressant. I think we did discuss some time back. It's a dopaminergic drug. It doesn't produce sedation. There is no weight gain. There's no switch is not there. No sexual side effects. Theoretically, 1, 2, 3, 4, 5, 6. It's an excellent point. But what is the point if the drug is very safe, but it's not effective? No. Very clearly, they said that if 50% of the prescriptions has escitalopram are good, obviously the patients who are there in US, they are not getting a good antidepressant effect, and that is why resistant depression goes up. Right, sir. This is not like, as I told that, this is one of those things I was trying to talk about in this. Choice of antidepressant, I'm sorry. I'll go back to that slide, what I showed. Choice of antidepressant depends on age. Really may not be. If it is tricyclics, I would say yes. But if it is SSRIs, I don't think it's going to be dependent on. Right. It's not going to be. Only thing is you may have to make some difference in the dosage. Yeah, what is your right, sorry, I think some of this missed. Right, I'll go back. When should we consider augmentation? Let us not talk about augmentation now, because I think we are looking at choosing an antidepressant. Augmentation is a later stage when resistant depression. I don't think this is relevant at present. Again, clinical biomarkers. I did talk about clinical biomarkers as mainly a family history in past episodes. I do use it as clinical markers. Effectiveness of trazodone. Somebody asked this question. So trazodone is, I think, one of those older group of drugs, which I'm not using it regularly. Hardly any patient. Few reasons. It's a sedating drug, so some people still use it. Trazodone was one of the drugs with a simple, with a side effect of priapism. So that is why initially all of us had some hesitancy. Beyond that, as an antidepressant effect, I don't have much of a thing. Adding non-pharmacological intervention and various approaches in treating BPAD. Right. This is a suggestion actually. Dr. Reddy, you're talking about only pharmacotherapy. You're not talking about any psychosocial interventions. Bipolar disorder, I don't talk, sir. Because now I even have something evidence to support me. CanMat 2018, so that psychosocial first line and the most effective is only psychoeducation. Rest of all fall below that, nothing more than that. Even in MDD, counseling is definitely a must. There's no doubt about it. You need to talk to the patient, reassure the patient, explain to the patient, educate the patient, give them, as I told that, last time I told, promise, because it's going to take about 3 weeks. These are all very, very important. Beyond that, I do not see really much of a role. It's my personal opinion. Some of you may not agree with that. That's why I don't talk much about it. How long should an antidepressant be continued once the patient has recovered completely? And can the antidepressant be stopped abruptly, or should it be tapered off? An excellent question. Dr. Janaki, I think she has asked an excellent question. We are all taught that you give an antidepressant. This is one thing. You acute phase, you treat the patient. Once the patient remission, then continuation phase till recovery, that is that 8 weeks or 12 weeks. After the recovery, maintenance phase for about 9 to 12 months. We all have been taught about it, and we mostly follow that also. But some of our patients throw surprises to us. You treat the patient, he recovers, he doesn't come back to you. He disappears. He'll come to you again after 3 years and say that you treated me that time, I became all right. After 1 month, I stopped the medicine, I did good, no problem. So that's so this 9 to 12 months dictum, it was a dictum, but I think now we can make it individualized. Maybe some patients you can try to stop even maybe earlier. This is going to have again very good positive impact on the like therapeutic benefit in psychiatric patients. Once you go there, you need to take the patient medicines for 1 year. Need not be for all the patients. Some patients, when it is required, we give, but it can be. I do try it at the end of 5 6 months. And then do you stop it abruptly? Generally, we don't. But I don't take too long a time also, like 6 months or something. Suppose escitalopram 20 milligrams to zero. Maybe I do it in about 3 months period at the most. Reduce and then stop it and then see how the picture is. Lot of them do well, but some of them don't do well. It's something like that. You have to make it individualized. But it's not that every patient has to be continued for 12 months. That is what. Role of combining two antidepressants of different class in the treatment of MDD. This is again later stage. We are not talking about resistant depression, non-responding depression at present. Later stage. Here it's like this, sir. There are some guidelines given to us. You follow the guidelines and then treat that. SSRIs are the treatment antidepressants for depression. We all follow that. After 6 weeks, after 3 months, if the patient is not improving, then it is your clinical skills. Augmentation, switch, augmentation with what, viscity, it's all very, very arbitrary. Study does not say any difference between level 2, level 3, level 4, did not differentiate anything at all. So you can give lithium sometimes, you can give thyroid, you can give the second hand. It is going to be trial and error depending on that particular patient, how you try it. That anyway, we are not looking at it. We are looking at how do we initiate the antidepressant treatment.
Dr. Zaman has a question.
Yes, yes, sir. Yes.
Good evening, sir.
Good evening.
Combining
Why don't
lithium with
you make it video? Chintan, why don't you come alive?
that means double mood stabilizers. Will it work in resistant cases?
In depression, sir?
I am yes, depression in bipolar disorder.
Bipolar, see, sir, one thing here actually, I'm sorry, we are today talking about only about the major depressive episode. We have major depressive disorder. We are not talking about bipolar disorder, but the question has come because valproate antidepressant efficacy is highly questionable. Even lithium is highly questioned. Combining these two, how far this is going to be? If you ask me, my answer is I will not do it. I'm very unlikely, sir. But today, anyway, we are talking more about the major depressive disorder. And medication of choice during pregnancy and lactation. I think this is a very, very important thing. One of your patient, somebody you know, had recurrent depressive disorder. Now, during pregnancy, she has developed a significant, fairly severe depression, moderate severe. It depends. I am fairly confident with escitalopram, sertraline, fluoxetine, these 3 drugs. They all come in that category C. Doesn't mean that there's a 0, category C. If I am comfortable, my therapeutic alliance with the family is good, I will keep the patient on that. That is why I said that I think one of the slides, pulmonary hypertension in fetus is one of the risks with SSRIs, but that's an extremely rare risk. You have to look at what is the depression burden on the mother and maybe like on the fetus, and what is the risk with this antidepressant. This is what I have to look at. I am reasonably comfortable. There is some literature also for sertraline and then escitalopram and even fluoxetine. They say that after a few years there are some attention deficit problems and all things are there, but we have to treat. But that depends on your relationship, because this is a little bit more than a medical issue, it becomes a social issue, sir. Antidepressant for pain symptoms, I here once again, sir, when you say pain is a symptom of depression, I treat antidepressant, every antidepressant, that is automatically it's effective. That's what I look at it. When you treat typhoid, your backache, headache, and then other GI symptoms and all, once the typhoid is gone, all the symptoms are also gone. In the same way, I look at this pain. I will not give separately some other drug for this. The same drug, supposedly it's supposed to work, and it did work. It works most of the time. That is what I say that. Antidepressant less likely to cause hypomania. One just now we discussed possible bupropion. Maybe another drug if you want me to tell you, maybe tineptine. I'm not at all convinced about antidepressant efficacy of tineptine. Maybe, but it's still an antidepressant. It can be the drug. I do not know.
So Dr. Yashika has a question.
Yes, sir. Yes, sir. Please go ahead.
Good evening, sir.
Good evening.
Sir, actually, I had one patient. He's a 80-year-old male, and he's having like anxiety features intermittently during the daytime and sleep disturbances during the night time. So I tried giving him escitalopram, but he was bent on not taking it, and he felt that the symptoms are not severe enough to start an antidepressant, and he was like, I just want temporary relief. So I started him on clonazepam. So he's better with it, but since 1 month I'm giving him, but the symptoms are still continuing. So then how to counsel him to explain him that you have to take antidepressants?
That's $1 million question. This is one of the reasons why I keep talking about it is that you have major depressive disorder, you need antidepressants.
Yes, sir.
That simple statement, I know, when I'm talking to you like this, I know the difficulties. I'm not trying to tell you that, okay, you go and tell that your patient is going to accept that. No, we all have the problem. Part of the problem is, some of you are going to get angry with me, part of the problem is with us. We talk about, that's where I said that we go onto every platform and talk about CBTs and all those things, and drugs are not necessary, drugs are harmful, wrong term. We keep talking about it. And that is where still in the public, they have, that's what I told that normal sadness, you call it as MDE. Antidepressant is a safe drug. Give it a clinical trial of 2 months, but they refuse to take. I understand, I completely understand what you're saying, that because again, there's some, like in the literature somewhere you would have read, or some of your colleagues would have told that, no, these antidepressants produce hyponatremia, certain. That is what we
Yes,
are
sir.
discussing. I think you're perfectly right. This is the problem. This is the problem we face. And then sometimes you feel so sad that this man possibly, I can't say that, could have been helped by the small dose of clonazepam plus escitalopram, but he doesn't get the benefit. This is why this exercise, the entire exercise of it, good prognosis, treated, safe drugs we have, good prognosis disorder, safe drugs we have, we can use it. That is what I completely understand. This is what I face every day.
Yes, sir.
You're right.
So like he was saying that he's having excessive thoughts after just the first dose. He was not giving it even a chance to take the medication. I explained him that you'll have to take it for at least 2 weeks. So then, like, does it happen? The excessive thoughts and all with escitalopram?
This is exact. This is what now, like just now I was discussing with our Murali sir. Suicidality increase. They just go and Google, because people are morbidly, even today, people are morbidly scared of all our psychotropic drugs. Part of it is our EPS and whatever it is, it has happened before. But depression, as a natural process of the illness, there will be fluctuating severity of thoughts and negative thoughts and anxiety and all that, which is very common. So that is what I talked about, nocebo effect there. The opposite of placebo, nocebo effect, they attribute everything to this and they're worried.
Yes,
This
sir.
has to come down. I think Dr. Murali has perfectly told that very rightly. More than us, it is physicians and neurologists who write these antidepressants. But they also have to be explained that these doses, they are very safe drugs. That is why I sometimes now like ask a little bit. That's why last time that question also, even sometimes I ask a very stretched out question saying that, suppose I give escitalopram to somebody who is about 50 years now like in the escitalopram 20 milligrams for the next 25 years. What is the problems or what are the long-term side effects? Or I keep asking that. Just to
Yes.
not push the point. I think this is the problem we are all facing. The same
Yes, sir.
context, last time also I told, a teenager comes to you, you start antidepressant, father goes and Googles, and then he says that there's increased suicidality. Which father is going to give that son the tablet? They're scared, they give it, but they're so scared. This is where some change has to come. You're right in asking that. But there's no other choice. Only thing I look at it is that quite a lot of time there's a possibility of natural recovery also. They come out of it. That also helps.
Yes, sir. Thank you so much, sir.
Yes, thank you. Selection of antidepressants in the special population. Sir, here I think this is again becomes, that is where, see, somebody asked me, what is the antidepressant of choice? I said escitalopram. And then here somebody asked, senior psychiatrist Prabir Pal has asked, what is the antidepressant in special population? The same question. Suppose I say, sir, escitalopram or sertraline. Let me not talk only about escitalopram. Let me talk about sertraline also. Escitalopram or sertraline. I can give it to a 10-year-old child. I can give it to an 80-year-old man. I can, just now we talked about, can be given reasonably in pregnancy lactation. Can be some dose titration, can be given somebody in the renal failure. Can be given with some dose titration somebody with a hepatic failure. What is the absolute contraindication for giving these two drugs unless there is a hypersensitivity? But with slight dose titration. So that is where the only thing what we need now is that an antidepressant, if escitalopram is showing its effect in a week, absolutely it would have been a dream antidepressant. That is not there. So I would once again go back to these two drugs. If somebody is a lot of sedation, I use fluoxetine fairly cautiously, looking at the other drugs what he is having. That is it. Which antidepressant you would like advice for long-term treatment of MDD in very young age? Either fluoxetine or escitalopram, sir. Definitely. The dosage you need to adjust. And then there is one question, bupropion, buspirone, and then benzodiazepine. Single drug is mostly, sir. See, the only reason why I say that is that quite a lot of times monotherapy is helpful. If it is not helpful, go ahead. The moment you start combining two drugs, after some time when the patient has recovered, you don't know which drug has helped him. So we have to unnecessarily continue that. Why? Again, polypharmacy is one of the main reasons where there is more of non-adherence. That is the reason. We have to be. Won't antidepressants, MAO inhibitors, I already told that I do not have much of an experience. Won't antidepressant cause cycle acceleration in bipolar disorder? This is a highly debatable question we have been talking about. People who strongly argue for it, but there is also an argument saying that it may not really do the kind of a damage what it is you're supposed to be. Let us look at this point from two angles. On one side, people say that it produces cycle acceleration. So we give so-called prophylactic drugs. It should supposed to help. Right. Second thing is, if antidepressant is the drug which is helping, which is required for the management of bipolar depression, are we more worried about the cycles later or immediate suicidal risk of it? That also we have to weigh and see. That's it. That's the only thing I say, that nothing more than that, maybe a possibility. Antidepressant, no, I'm sorry. Okay. Like most safe and effective, again I say that like if anybody strongly disagrees with escitalopram and sertraline being largely safe and effective antidepressants, sir, please come again, please put a question, let us discuss about that. What do if a patient develops myoclonic jerks at night while sleeping when he is on antidepressant showing response in depressive symptoms? This is one phenomenon which I also have noticed, actually this particular phenomena in the night time especially, they're talking about some jerky movements which is looking like microneedles. More commonly I noticed with vilazodone. See, we know that all of us know that almost all the antidepressants with varying severity reduce seizure threshold. So sometimes I am worried that whether this is the pre-indicator for a seizure. So I'll be a little bit worried. Immediately I reduce the dosage. But then again, if you say that he is very effective, therapeutic dose is maintained, maybe I will change the antidepressant. Mostly in the SSRIs only, but vilazodone I saw it more frequently. The other question about the leg cramps, I'm not very sure about what you're talking about. Role of vortioxetone, I've been writing this drug, but it's extremely costly, 150 rupees a day, very few patients only. So we are actually one of our postgraduates is started a dissertation work trying to see cognitive impairment, two groups of patients, one on escitalopram, one on vortioxetine, and trying to see whether at the end of 6 weeks whether there's any change in the cognitive impairment or a beneficial effect with vortioxetine. We're trying to see newer antidepressant versus old antidepressant. New antidepressant versus old. New antidepressants are mostly SSRI, some other things which have come recently, vilazodone and then vortioxetine, we talking about it. Study management of cyclothymia. Here I think maybe I will also ask some of you to, cyclothymia is described as one of the, in the classification of bipolar disorder, but nowhere we do treat. It's passed up as a minor, more than normal variations of mood and stop it at that. I think sometime back when I was talking about bipolar disorder 2, when I said that bipolar 2 disorder is a myth, compared to bipolar 2, cyclothymia, at least textbook description wise, it produces more disability. And it actually, if you ask me, there are minor ups and downs, but they are supposed to be giving a significant disability, and that is where all our prophylactic drugs should be tried and tested to smoothen out that curve. But really, people do not talk much about it. We usually don't diagnose and then treat that. How do we manage the pharmacological side effects? Yeah, side effects of antidepressants, one of those is especially the problem with sexual side effect, dose reduction. GI side effects will go in a few days. Sexual side effects, once you reduce the dose, it slightly becomes better. If the minimal dose, if it is continuing, we have to change the drug. Right, again the question is that do we still continue with antidepressant after the patient is off the depressive mode? Yes, I think that is where we talk about the so-called remission recovery. I don't know whether I can get this example, but it may not sound very clearly. After your sputum test becomes negative for tuberculosis, we continue the medicines for the next 6 months. Whatever may be the pathology, which maybe we know the pathology, we can clinically demonstrate, but here we may not demonstrate, and the natural course of it. That is why we are supposed to be continuing antidepressants. So here, patient has major depressive disorder, melancholia, let's see, has come to you. I've started him on antidepressants. He recovered in 4 weeks. Then the question is, can we stop it? We were talking that we cannot stop it. We need to continue for a longer time. All of us treat most of our patients with ECTs, quite significant number. How frequently do we give maintenance ECTs? Even maintenance ECT, the term is there, but I don't think any of us even think about it. And even if there is one, I had only one patient who is to come once a month and then take it. If your patient with depression was benefited by ECT, logic again demands that you need to give maintenance ECT also. But we don't do that. But with antidepressants, we do it. I don't have an explanation that. When do you choose an antidepressant over a mood stabilizer? Here again, I think we are today talking about mostly about major depressive disorder. Let's not jump to bipolar disorders. Again, it's like that. For management of bipolar depression, I think antidepressant has to be given unless it is you have the history of now very frequent cycling and then very horrible, now like in a very acute psychotic manias, we can give. Best mood stabilizer, right? Again, the bipolar question. If you ask me again, I'll go back to lithium. Which specific antidepressant is more effective for retarded depression or agitated depression? I think, yeah, maybe here there may be some difference. Mostly, I don't differentiate, sir. I give a citalopram sertraline. But clinically, for a retarded depression, fluoxetine can be a better choice. It's more of a stimulant. Agitated depression, paroxetine can be a better choice because it has got a mild, like a sedating and anxiolytic effect. But we can try that. But what I say is that as long as the depression, the component is there, unless your drug is adding to that retardation, there's no problem in giving an antidepressant. That is what I feel. Latest clinical algorithm is management of bipolar disorder is CanMat 2018. I think we'll go back to that. But there is one particular mail has come to me, Dr. Neha Lal. I think this is a very interesting question the doctor has put. A 30-year-old patient of OCD with secondary depression. Have tried him on optimal dose of fluoxetine with risperidone augmentation, paroxetine with clonazepam and risperidone. He was previously tried on fluoxamine but did not help much. My question would be, how high can we go for fluoxetine dose and what other augmentation can be used? Also, he repeatedly complains of sleep disturbance which has not responded to benzodiazepine drugs. Can we discuss this? OCD is the primary diagnosis. Again, it slightly deviates, but still I got some slides to show here. There is depression. Fluoxamine has been tried, but did not help much. So let us roll it out. And then fluoxetine with risperidone augmentation. My point is, when did you add risperidone for augmentation? At what level? Because risperidone itself, also risperidone is the drug, I know that, but that also can release some OC symptoms. And paroxetine, really not the drug usually we give for OCD. And clonazepam we do give. And sleep disturbance not helped by benzodiazepine drugs, we can go up a little bit more. Long time back, there was a theory that high dose of benzodiazepines also to a certain extent help in OCD. Like that we can go. Here the question is, how much higher dose can I go up on escitalopram, sertraline or fluoxetine so that my patient gets a better relief? Just I want to show you this very interesting actually that was, but how much some of you will agree to this, and I was not very okay. Let me go to that and then come back. Oh yeah, right. Yeah, this particular slide, right. If you look at this forest graph, SSRIs, venlafaxine, methotrexate. Here what they say is that this is a flexible dose. That is like let us say escitalopram 20, 30, 40, 50, 60 like that. This is a fixed low dose. What is the fixed low dose? That also let me come to you first. Yeah, right. This is if you look at this, first let us look at this slide and then we'll go there. SSRIs, escitalopram, maximum dose they said is 20. Maximum dose. This is sort of the low dose. Fluoxetine can go up to 80. Paroxetine 63. So escitalopram it's only about 20. Venlafaxine 225 is the dose. Beyond that increasing, they say that maximum dose is only 220. By this, I think one of the papers I took it. Desvenlafaxine is going beyond 100. No, maximum dose. This is what they prescribe. Let's not worry about this. So escitalopram 20, fluoxetine 80, and then when desvenlafaxine, venlafaxine, this is the maximum dose. So when they say maximum dose is this, they are talking about two things. Either increasing the dose further may not help, or it's going to give unnecessary side effects. This is the one, right? Now coming to this, Here again, the same thing this shows that acute phase treatment, I'm talking about MDD, but you asked about OCD. I remember that. I'll come back to that. Maybe same thing will work for OCD also, I don't know. Flexibly titrating the dose while side effects permit, no increase in efficacy and acceptability. So increasing the dose of metazapine, increasing the dose of sertraline, paroxetine, escitalopram or citalopram beyond whatever the maximum dose is given, increasing that is not going to help therapeutically. That is what this particular paper says. But for fluoxetine up to 80, you can. Venlafaxine also up to 225. For venlafaxine, right. But not beyond that dose. But here, do we follow the same thing when it comes to here? Maybe I would, what are the, let's now, like, because we have come to here, let's look at the tolerability and then maybe 2-3 slides I'll show. This is again superior efficacy, tolerability. These are the drugs, efficacy wise 1, 2, 3, 4, 5. Very highly superior, not very much. I'm really shocked to see that fluoxetine is put under inferiority when it comes to efficacy. Absolutely not. If you ask me, definitely it has to be here. And this is overall tolerability, highly, very well tolerable and not so well tolerable. If you look at this, escitalopram, agomelatine, vortioxetine. What is this? Here they showed that, yeah, green indicates these agents also had superior tolerability. Red indicates inferior tolerability. So escitalopram is a good superior efficacy and also good tolerability. And vortioxetine, again, we don't have much experience. Venlafaxine and amitriptyline are very good efficacy, but tolerability is poor. But agomelatine, how many of you tried agomelatine? I don't know. No, like that is fair. But this is what according to that. So even here, my favorite drug has come, escitalopram. That seems to be both effective and also good tolerability. Now look at the side effect profile. I think this is maybe, before going on to that question, how high we can go on the dosage, I wanted to have a look at it. If anybody has a serious objection or something we have missed, let us see that. Transient side effects, let's not bother. It's only for a short term. Often persist, dry mouth, drowsiness. This is right. We did talk about 25-30%. We have the sexual dysfunction and then those related. That's one big problem with all these SSRIs. Serotonergic syndrome. Sir, with pure SSRI in the last 25 years, I have not seen even a single case of serotonergic syndrome. I do go for very high doses. I'll come to that when I talk about the OCD. Bleeding risk. I had 2 patients. There's a temporal relation. After starting this, he had now like a J bleeding. This I don't have. Hypomanic, right? I don't bother about hypomania. Right, this one. Underlying, this one is again plus minus. Bipolar disorder, which is like, whether they're already bipolar, that let's not worry about. Serotonergic syndrome, these are extremely rare side effects. It is something which we should not bother about. Maybe 1 in more than 100,000. We write so much of antidepressant. Age specific over 60. QTC prolongation. This we keep talking so much about it. I think we do ECGs also. And thyroidazine was one drug. Then giprosidone was the drug. Of late, quetiapine was one drug which has been. But with the antidepressants, even citalopram, sertraline also talked about, but really not so much. Hyponatremia. We keep checking. Of late, I've been checking about now, like this sodium levels. It's not very frequent. Even when there is, suppose there is a hyponatremia, unless it's significantly low, comes down to 110 levels. It's nothing really. And then you send to a physician, they say that take a little bit more salt, nothing more than that, most of the times. Falls and fractures, I don't know. The age above 60, anything which produces sedation is a risk of falls and fractures, which we have to be extremely careful. That is why when that 80-year-old man refused to take escitalopram but was taking clonazepam, we are more worried about this. And then this. This is what Dr. Murali, I was talking about. How long this is going to be there? These are all things. So, no, these are all extremely rare side effects. This is why I say that we have antidepressants right now, those 2 antidepressants, as safe as paracetamol, maybe safer than paracetamol in the long run, in spite of all they talk about. All right. Right, I think the doctor's question before that. This is one interesting slide I want all of you to see. This really interesting. That's why I got this slide. Most common medication prescribed, requested on psychiatric advance directive, refused on psychiatric advance directive. It's really, these are the drugs which have been prescribed. See, like suppose the first time a patient has come to me, these are the drugs I prescribe. Then after the first time treatment with me, this man goes back, once he becomes euthymic, he writes an advance directive. In that advance directive, they have all the right to say that you can prescribe these drugs I don't want. This is a beautiful thing here. If you look at this, requested on, these are the things which are requested, refused on psychiatric advance directive, which is this 30, which is a high number. This is 24% of the patients refuse this drug, which is this haloperidol. 25% of the patients give the patient a choice. He refuses to take haloperidol. Now we understand, sir, how we pushed haloperidol down the throats of these patients, but we didn't have a choice that time. Senior people know that we didn't have this one, but refusal. Now coming next, which is the other drug. Surprisingly here, even 11% fluoxetine also they refuse. Maybe this explains this fluoxetine, a lot of patients releases anxiety. They feel a little bit more anxious after taking the drug. That could be. Then 23% lithium. Now you understand why lithium prescriptions are going down. One of the reasons, this may be one of the reasons, patients are refusing. 23% of the patients, they said that I don't want lithium. Next time I become sick, I don't want to take lithium. I don't want to take haloperidol. Don't give me fluoxetine. Surprisingly, you know, like, and this is what, and again, chlorpromazine, 17%. They said, I don't want chlorpromazine because it produces it. So these are all sort of reasonably user-friendly drugs. Your venlafaxine, aripiprazole is again, right, well tolerated, escitalopram. These are, so I just wanted to show you that, see, like sometimes what you're not writing haloperidol now. Patients also don't want. All over the world, God knows, lithium is a gold standard, but it's not being, chlorpromazine we are not writing, even patients don't want. Just for that, I wanted to show this term. Right? Now, coming back to this question about obsessive compulsive disorder, like fluoxetine, how much high dose you can go up to? According to this, 80 milligrams. So this is again, I think it will be open for discussion also. Some of you also can pass your comments. Escitalopram, OCD, I don't say that I have a great experience, but I keep going up to 80. There are one or two patients I went up to 100. But when I went up to the high dose, one of my friend from Nimans, is a close friend, he said, no, what are you doing? I don't think this is going to help. Nimans OCD clinic, he says that very clearly that beyond a dose, it does not help much. So no point in giving, but I did find some of the patients when I went up the dose, it was helpful. But of late, I'm becoming a little bit more cautious about it. Fluoxetine, I'll just tell you one patient's history. This patient was being treated by somebody else on fluoxetine. And then she was on, I think, 40 milligrams, I think. And she came to me, she said that she's much better on fluoxetine. But at the same time, still a lot of symptoms, doctor. That is why I came to you. When I put my ABC, I put there as my clinic for both mood disorders and also OCD. I think some of the patients come like. So I said, anyway, patient is being benefited with fluoxetine, might as well increase it. Fluoxetine is no problem because she is not on any other drug. So I increased it to slowly to 80 milligrams. After 3 months or 4 months, this lady comes back and tells me that, doctor, this is the first time in my life I am feeling so good, so relieved of symptoms. I said, it's very good, right? My increase in the doses has helped. Finally, when I wrote the prescription, she said, write the previous one also. What is that? You gave 80, I was taking that 40 also. Totally, I'm taking 120 milligrams. I just got a shock of my life. She is taking 120 milligrams and that is in a open remark. It's not on inquiry. She said that the first time I'm feeling so good. So OCD is one condition where, given the side effect profiles and if the patient is able to tolerate it, I would say that we can slowly go up, but this depends on educated patients and somebody who are not, even their therapeutic syndrome was not there. That is exactly why optimal dose, even fluoxetine, even otherwise they give 80, we can go beyond that, but you have to be very careful about other drugs, what the patient is taking. Escitalopram, I do go up to 60 milligrams, 80 milligrams also, but mostly I try on that. If it doesn't work, I go to clomipramine, which is not a very friendly drug, but I do that only after trying clomipramine, then I'll go for risperidone or other augmentation. Otherwise, I don't go for that. Nowadays, we are trying RTMS and TDCS also with that. CBT anyway, now like in counseling anyway, we'll go on with that. So we can go up to 80 milligrams of fluoxetine, even the textbook wise also, you can go a little bit higher, but slowly explaining the patient. And if she is not tolerating fluoxetine because of that escitalopram or sertraline, fluoxamine, I don't have much of an experience, but fluoxamine, I feel that it produces more side effects compared to these two drugs. That is what I feel. I hope I have answered your question reasonably well. Now, augmentation agents, let us not talk about augmentation agents, sir, because now like that's the later part of it. I don't think we are only starting it to start with. SSRIs may be less effective in women over 50. I feel that they are reasonably effective in all the age groups. And right, if there are any other questions left in that? Yeah, I think the 50 questions, maybe we didn't answer each and everything, but now like in most of it, we tried to answer that. People are asking about STAR-D. We did discuss about STAR-D. CanMat is one of the latest ones. And other than mood disorders, anxiety disorders and all, I think we have to look at somebody else also to talk on that. MAO inhibitors, I don't have much of a experience. And initiating, what is your suggestion on initiating bupropion in young sexually active males with moderate to severe depression? Here one thing is, if you ask me, I will not, sir, because bupropion therapeutic efficacy, I am doubtful about it. So I will go reverse. I'll start on escitalopram sertraline, see how the effect is. If they have a significant sexual side effect, maybe then I'll come to bupropion, not straight away to bupropion. Bupropion, I generally don't start on the first line drug because I am worried about two things. Number one, efficacy. Number two is the tolerability. Somehow with bupropion is not very good. Put the patient on SSRI, recovery is due to the drug or natural course of the, absolutely. See, like, see, that is exactly what I told. The natural course, the only thing I think I've been showing 2-3 slides, our job is to shorten the course. Fine. I have no problem when somebody says that you have given escitalopram, the patient is now like recovered, it's a natural course. Also no problem, because these drugs are safe drugs. The same thing I don't agree in case of bipolar disorders in polypharmacy. Maybe I would not have agreed if it is tricyclics, but because of SSRIs and these drugs, maybe I'm sort of not like an agreeable to that. Some of you may not agree, but that's a different thing. I'll agree to that. When do you stop an antidepressant? If the patient recovers in the standard, if a patient recovers in 3rd week or 4th week, MDE is less than 8, less than 7. Nowadays, I'm trying to stop the medicine by 6 months. I'll come to that. I think, yeah, some of the slides, how do you know what step-by-step procedure. Mirtazapine, I don't have much of experience because 2 reasons. Mirtazapine is sedating. I don't like much sedating drugs. Second thing is weight gain, okay, right? But sedating drugs, I don't like much. So that's why I avoid it, nothing much. Is bleeding risk with SSRIs is so high? Definitely no. Among TCAs, which is your choice, I use mostly nortriptyline because side effect profile is less and then the dosage also. This is another peculiar drug which has got the therapeutic window. Higher doses, again, supposedly not effective. Lower dose are not effective. Maybe around 50, 75. It's supposed to be effective. I use nortriptyline fairly. Health coaching, right, sir. I think maybe I would request you to say a few words on that. Dr. Nirmal, can you explain us what exactly are you talking about? Psychoeducation or something more than that? Health coaching. Chintan, can we unmute Dr. Nirmal, and then he talked about health coaching. I'm not very sure about what it is.
Sir,
Yes.
thank you, sir. We have been, I think we all know that we have been struggling with adherence issue in patient with bipolar or depression. So health coaching is a concept, sir, in which we try to make the patient or the patient party own their illness. They own the illness. By that, what we focus in health coaching is we try to explain to the patient. It's a combination of psychoeducation, counseling, and psychotherapy a bit. So it's not a new concept, but I find it very useful because when they own their illness, usually what happens is uh, I don't know about in India, but in Nepal, what we try to do is after diagnosis, we write them medication and we tell them that you should be taking this medication. And I found that in my practice that is not enough. Like Dr. Reddy showed us in that slide, what is the percentage of chances that the patient will actually go to the pharmacist and take the medicine home. It starts declining from there onwards. So in health coaching, uh, it's a teamwork where
Yes.
the clinician, after when the clinician makes the diagnosis, then he does his bit regarding explaining about the patient, about the case to the patient. Then there is a team of health coach which comprises of trained nurses, trained paramedics, who would be trained to give psychoeducation regarding the illness in local language. They will be given leaflets, audio visuals, and then once they agree with the diagnosis and they agree with the lifestyle changes and the need for treatment, then the role of the pharmacy comes, and pharmacy, they make the sure that the patient has understood. So this is basically the concept of health coaching, and
Right.
I
Yeah,
find
I
it.
think exactly. Thank you. Thank you so much. It's a collaborative care. What people
Yes,
talk
sir.
about is collaborative care, health coaching, which includes all. I think wonderfully, like in every single aspect has to be taken care so that your medicine is taken regularly, taken very, like, scrupulously taken till the point of recovery. The whole team, a pharmacist, and then now like in
Sir,
the doctor, and then
I add one more thing, sir.
yeah, yeah.
I beg your pardon. And then in the community level, we also follow the patient. Like we would call them in regular interval, or the office would call them and make sure the patient is taking medicine. So all this comprises health coaching, sir. It is very much in practice in Western world. So that's it, sir. Thank you.
Thank you. Thank you so much. There are one or two questions here, and then I'll go back to my slides also. Like, yeah, right. What is the highest dose I've gone up on escitalopram without much of side effects? 80 milligrams. 80 milligrams I've given a few, not like in a patient, but of late I've seen some of the literature saying that going beyond 20 may not help so much. I've sort of slightly cutting it down. And ketamine, right, we did talk about some time back, and then I think comments saying that fluoxetine higher doses definitely helps in the management of OCD. Gastric. When do you stop? Most difficult task is that when to start tapering. As I told, that it all depends on, but maximum about 9 months I try to taper it off, unless it is one of the chronic. Sometimes it's very difficult to taper off. The patient is different, but average patient I try to taper off early. At this point, let me show some of this and then sorry. Yeah, I think he was talking about now like in health coaching, and then we saw that adherence problem, how much it is. That last time also I told that how do we make the patient more adherent to the medication? This is what one of the main problems what I saw in STAR-D. Can we follow this? This is the same thing they followed in TB treatment. I want your opinion also. This is what I do in my clinic. I lean more and more and more on the caregiver, because caregiver I feel very important, because one is that negative cognition to the patient, and a lot of times it's the caregiver who dictates, who takes the main control about it, because sometimes lack of insight, sometimes negative cognition, sometimes that like it's a kind of a problem, psychiatric problem has got, it's a caregiver completely dominates the scene. So I almost say that.
Yes, sir. Can I have?
Yes.
Can I come in, sir? Yeah. That is one thing. You have spoken out something from my heart, sir. From the very beginning of my practice, I had been telling to the government agencies, the health ministry and Department of Health that in a given time, I think this is what will be required to treat some psychiatric patient for adherence. That is DOTS model. So in health coaching, I think in health coaching, this is one thing we can monitor, through our community health, like community workers. So this is very, I think this has to be implemented, and it was nice to know that you have been doing it in your practice.
Yeah,
I would definitely carry this forward.
Thank you so much. See, when I was looking at the TB treatment, it's the same kind of figures. You have an infectious disease, you have a good treatment regimen, but the response rates are 30%, 40%. So that is the stage they looked at what exactly is happening. They said that it is an adherence problem. It is the same problem in management of MDD. At the end of 1 year, attrition rate in STAR-D was more than 90%. Tuberculosis treatment also the same thing was happening. Then they came with this directly absorbable treatment where Asha worker goes into the house and then gives the whatever the like in 3 or 4 tablets. They have seen phenomenally the response rates and the recovery rates have increased in tuberculosis. Now all over the world, even in the developed countries, it is a practice which has been like regularly practiced in the management of tuberculosis, where the results have substantially improved. It's not with the new drugs. Maybe there are some resistant cases, but that is where I felt that I don't need 10. I give only one antidepressant. That's why I was talking about monotherapy. Monotherapy, escitalopram, sertraline, one drug helps. You don't have to have a Asha worker to go. Your own family member is there. Only once a day, night after dinner, put one tablet in her mouth. That's it. That is the only thing. At the end of 3 weeks or 4 weeks, most of the patients improve. Unless we do that, caregiver is a very, very important person here. That's mainly because of the patient is already negative, depressed, hopeless. He doesn't believe you. And then there is a 3 weeks gap. So you have to be heavily dependent on caregiver. So sometimes when the patient is a doctor, it's exactly same way to doctor, and please, I'm apologize to you. Please excuse me. Your wife is going to give the tablet, doctor. Some people are angry with me, saying that what the hell? You mean that I don't take a single tablet? Doctor, you take, but 1 month, please let her give. Because that is the problem. Because the problem is, I think I showed you, even in hypertension, only 70% of the people take. Diabetes, 50%. There is no problem. 10 days you stop the medicine for hypertension, 11th day you take, 12th day your BP comes down and sugars comes down. But my drugs do not work if you miss it on 4 days. That's the biggest problem with antidepressant today. Unless you take it regularly for 3-4 weeks, it doesn't improve. And the patient has got negative cognition. It doesn't see immediate response. And people do not supervise that. It's gone. That is why 89% of treatment gap Is it because of that? That is what. That's exactly. That is where I said promise. You're not supposed to promise. But because of this negative cognition, hopeless things, to inject some kind of a hope into them. It's okay, sir. It's okay for depression, you promise them. Rest of the disorders, you don't promise them. For depression, please, if you have to promise, you have to be confident about the drug. You have to be confident about your diagnosis. You have to be confident about therapeutic efficacy. You also have to be confident about the safety of it. Only these factors meet, you can wholeheartedly convey the promise. We can say yes, yes, but it doesn't get conveyed. So you have to believe the diagnosis of MDD. You have to believe the diagnosis of good prognosis MDD. You have to believe that antidepressant, escitalopram, sertraline are good drugs, safe drugs, active drugs, they are effective drugs. ठीक है, वो पूरा होने के बाद, if it doesn't work, what happens? Give it a 3 months trial. If it doesn't work, we all fail. Medical doctors are not like they're going to make the whole world healthy. We all fail. Outright, straightforward case also, we feel it's okay. That is where he said that two models we have to. I think Dr. Nirmal was talking about collaborative care model where you get the patient also inside, but also at the same time, you know better. That is where Gandhigiri, I said that Gandhigiri has to be done here. Don't try and say that go and take the tablet, they won't take. Somehow you have to convince. There's a group of patients, at least in the Indian setting like that, that you are the Vaidyo Narayano Hari. Still there are some people who believe that Doctor Sahab tablet diya, theek hai main le. That both the things you work, this is the most important thing for me. So a lot of times I told that your stigma does not go by going on talking just on TVs and then newspapers and then writing articles and also. One of the most important thing is bringing out recovery in a patient with psychiatric illness. Every recovered patient is going to be an ambassador. He says that, yes, I had the problem, I recovered. I don't say that I had the problem, I recovered. I'll convenient because I'll say my friend has the problem, he recovered, you go to the doctor. That is where we have to. I think last time I was talking about, last time only, why so much of hue and cry about bipolar disorders? This is one I'm latching on to. I'm holding on to say that psychiatry, there are some illnesses which are curable. The episodes are curable. Like, go ahead, I'll treat your depression, 3 months, 6 months, and stop the medicines and go. Next time you get after 6 years, we'll see. What difference does it make to the patient? This is what the regimen I follow. I try my best. First 1 week or 10 days, I see the patient 3 times. After that, I tell them come after a month. Then I give them 3 months or 4 months like that. These are the things we have to look at. That is why I thought I'll show this slide. And yeah, this is the personality. I think maybe not now. I think it's, maybe sometime later we'll come to this. Here there's one slide which I wanted to show. We all talk about CBTs. There has been so much of a criticism on antidepressants. See, this is, it may sound a little bit silly, but still I think all of you have to know. Antidepressant efficacy, there are especially Erwin Kirsch's book, Emperor's New Clothes, exploring the myth of antidepressants. He says that only positive reports are published, negative reports are not published. When you combine together, antidepressants are nothing more than a placebo. I think this is maybe the only one study or first study where I found that psychological treatment, what is the efficacy? The new paper, I think it's 2015. Studies which have been done where they are funded. CBT, IBT, we all know that CBT is there for. This is again, I was telling that last time. Treatment has to be applicable, replicable, affordable, accessible. Weekly sessions, hour-long sessions, 3 to 4 months, 4 into 3, 4 into 4, 16 sessions for every patient with major depressive disorder, 16 sessions of CBT. Oh, not possible in India. Maybe Dr. Nirmal also will agree, it may not be very possible in most of the population, Nepal also. It's not going to be. And then see the results. effectiveness of therapies dropped significantly. This analysis is the first effort to account for unpublished tests of such therapies. CBT, there are a lot of unpublished studies which show, we do not know. All things we know is that CBT is effective. And this is a study which said that not really something great to talk about. Right, it may be a little bit. So these are all the factors I was talking about, based on which we select antidepressant. And this is what I told, even 29% of psychiatrists told that they won't take a maintenance dose for schizophrenia. I don't know what is the reason. Right, this is anyway about schizophrenia, we don't have to worry about. And then I think I've come to this, and then let me see some of the, we have another 5-10 minutes. Yeah, this is the slide I showed. The bupropion, insula. Oh yeah, when I woke up, yeah, right, I think this will be the last slide. I know, like in the mail, I saw this particular paper. This is the latest, published on 14 July, American Journal of Psychiatry. Well-being, burnout, and depression among North American psychiatrists. Survey. So what do we do with this? This is so depressing. But of course, this is a very small number. 78% of participants, psychiatrists showed that they have burnout. My goodness. Now, fortunately, I think in India and Nepal, it's not such a high number. 16% had PHE scores of more than 10, which suggests MDD. NMHS study showed that it's a 5% in the general population of MDD. Among the North American psychiatrists, the incidence of MDD is 16%, according to this survey, which psychiatrists themselves have done. So I think time has come to say that physician die, like heal thyself, like psychiatrist heal thyself with all your, whatever you're talking about. I don't know what to talk about this, but right, higher PHQ is seen in burnout, understand female gender more. This is something which was very, very disturbing to me. This high burnout and then depression, old fellow like me, understandable. Yeah, residents in early career stage, why there are so many psychiatrists who are in the burnout and then the depression rating, and then non-academic setting practice. So all of us cannot be in like an academic setting. So even if you are doing some practice, my request is that if you don't want to go into burnout, once in a while do some webinars, be academic. So I think that seems to be one protective factor against the burnout and then depression. Right. I think that's the last slide, and see that if there are any more questions, otherwise we'll, yes. Imipramine and dothypine, I didn't talk about. So tricyclics, broadly, we all know that. I don't have to tell. Tricyclics are the drugs which we started with. As posterior dates, we had only tricyclics to treat with. SSRIs were not there. They are good drugs. Like even now, imipramine is a gold standard, but side effect profile is not at all favorable, including cardiac side effects, GI side effects, anticholinergic side effects. That is where they are not on the first line, maybe later down. Yeah, gastric irritation, reduced dose, exactly. Yes, somebody.
Young patient coming with severe depression and suicidal thoughts, refusing to take ECT. How will you treat?
Absolutely,
Yes.
Absolutely, sir. See, I keep telling, we have a DNB program running. People, I keep telling the DNB students, for 1 year, don't give EC2 to any of your patients. Then you will improve your knowledge of psychopharmacology phenomenally. You will realize how difficult it is, how much of a strain you have to go through. I think that is what Western psychiatrists are facing. That's why we see so much of resistant depressions. Sir, straight away, if you ask me, I will straight away start with escitalopram and a small dose of clonazepam for a few days and then pull it out. 20 milligrams. I'll wait for about 3-4 weeks. Definitely, counseling will go on 2-3 sessions. Wait for 3 weeks or 4 weeks and see how the response is. A lot of them do respond. If they don't respond, I'll go up to 30 milligrams or 40 milligrams, depending on whether there is response or he says that absolutely no change, doctor. Sometimes they say no change, doctor. Then I have to think about changing the drug. Otherwise, I keep increasing the dosage. It helps in majority. If it doesn't, that is the stage I add second drug. Nortriptyline is one of my favorite choice. Nortriptyline I add 25 milligrams or 50 milligrams, treat with that. Nowadays I am giving RTMS, suggesting them RTMS 10 sessions. That's also helping. In the process, I look for whether I am missing any psychotic symptoms. If there are psychotic symptoms, if I missed, they are not going to improve. And that is the main thing. Then psychosocial factors and all things, I really do not go much into the details.
You want recommend lithium to start with along with the acetalopram?
No, not to start with. Not to start with. Definitely not to start with, because any particular reason you asked that question, sir?
Yes, we come across such type of patients, severe suicidal thoughts and even have attempted suicide and comes with severe depression.
I don't start. For quite some time in some of these talks, when lithium, and there are only two drugs in psychiatry which have got supposedly suicide prevention effect. One is lithium, second is clozapine. Depression, the kind of a prevalence rates being 5%, every depressed patient is deemed to be a suicidal risk with 15%. Sometimes I was asking, why we don't start lithium for each and every patient? It's an anti-suicidal effect, but we don't do it because one is that its antidepressant efficacy, there's a question mark on that. And I am always worried about, we did talk about this also, patient with a suicidal risk, I'm always worried about the drug overdosage. If there is a drug overdosage, if it is lithium, we will have a serious problem. If it is at a later stage, I'll agree with you. But to start with, he takes 10 tablets of escitalopram. As I told that I don't bother. He takes 6 tablets of lithium. I'll visit Ray. Every place. Last time somebody commented saying that it's okay, what's the problem? There's a dialysis you can do. How many places we have dialysis centers? People don't even know that this patient has taken this and then he goes and then gets admitted in ICU. They do all that. Only later they come to know about lithium. So that is the only risk. And then, I don't know, sir. Sometimes, it's very difficult to say that, but I don't start. Later stage, an augmenting agent, I may start. But your point is that ECT, no. RTMS, I said, but I know that many centers don't have RTMS or TDCS. That's a thing. But I do. That's why citalopram or citalopram I go with. Later, add the second drug. Augmenting, we do give. Olanzapine, I give. Thyroid, I give. Lithium also is there. Aripiprazole, I don't try much. But these are the 3 drugs we. And then second drug, later stage, definitely I try. Thank you, sir. Somebody wants to ask a question. Chintan, please go ahead with Pinto sir.
Yeah, Dr. Charles Pinto sir has a question.
Yes, sir. Good evening, Dr. Charles Pinto. How are you? Long time. How are you, sir?
I think it is mute. Sir, you need to unmute Dr. Pinto.
Before that, somebody was asking atypical antipsychotic of your choice, along with SSRI, undoubtedly olanzapine. Because risperidone, I am a little bit worried about drug-induced depression. Aripiprazole produces a little bit of agitation, restlessness. Unless he is extremely sedating or weight problem, I would prefer olanzapine better than quetiapine because antipsychotic efficacy of olanzapine is better. Yes, Dr. Pinto sir. There is, I think here he has mentioned a psycho-educated carer is the best index for compliance and episode-free patient. Are you coming alive, sir? There is no doubt about it. But the carer has to be educated by us. How much of a confidence we give him, that is going to be the most important thing. These are all linked factors. We talk to them, but there are also other people who give them, Google gives them information, neighbors give them information, other doctors give. A patient on lithium, he goes to any other non-psychiatrist medical colleague, the first thing they see is, oh my God, you're on lithium, your kidney all right? Oh God. That is a kind of a thing they have, which is not going to be very easy for us to discount. I see some picture here. Is like Charles Pinto coming live? Chintan is?
No, sir, he is on mute only.
Okay. Then let's talk about, and then, right, I think atypical depression, then bipolar depression, one and the same. No, definitely. There is nothing like bipolar depression. Only certain factors are supposedly more. No, DSM-5 does not differentiate seasonal depression, postpartum depression, recurrent depressive disorder, MDE, MD, nothing. Only one or two specifiers, nothing more than that. Literature states desvenlafaxine above 50 milligrams is not useful. Higher dose of useful for your experience. I do go up to 100, but what I write desvenlafaxine is not so much. Yes. Somebody would like to say something or comment? Yeah. Your experience with SNRIs in MDD with predominantly somatic symptoms, do they really have an edge over SSRIs? Sir, shall I talk a little bit more frankly? SSRIs are the good drugs. SNRIs, venlafaxine was an excellent drug. Somehow, initially, because of twice a day or whatever the thing, it was not so widely prescribed, and it went, and then it didn't really take off. But venlafaxine, as an SNRA, venlafaxine is an excellent drug. Later, desvenlafaxine has come. Then duloxetine has come. Let me tell you, duloxetine, again, I think you will know, twice a day. It is, I never felt it is a good antidepressant. What I see is that antidepressants which are not very effective as antidepressants are slowly pushed over to as fibromyalgia, pains, and somatic symptoms. Physicians and the neurologists keep writing that. Milnacipran has come, another SNRA. Within a short period, it produced severe dysuria, and then it went out of the market. Now levomilnacipran has come. So among SNRAs, I have only one. The other two have sort of gone from as an antidepressant effect. That's a problem. So I cannot really comment on the group as SNRS, but if you ask me, I don't think it is really does much. Like 10 milligrams of amitriptyline, lot of neurologists write for neuropathies, right? There's an explanation because of the serotonergic system activity, but we do not know what exactly it is. Ketamine, I tried only 2 patients, so it didn't really help me much. Behavioral activation evidenced with escitalopram, it's a very good question, but I don't generally see it so much. That one is that irritability, and then tardive, that kind of a dysphoric mood and all. Generally not much. I don't know, because whether I overlook it or, but it's been described, but I don't see it much. Yeah, that's what we asked. Right, sir. Thank you very much. Drug of choice for atypical depression. Atypical depression also, this way the problem is, like, for everything I keep talking about those 2-3 SSRIs, nothing much with a small dose of this one, clonazepam, and nothing really much. Prothioidin, dotaipin is a good drug at one point of time. There is no doubt it's one of the good tricyclic antidepressants like long time back. Imipramine was supposed to be a stimulant antidepressant. Amitriptyline was supposed to be a sedating with more effect for anxiety. In the same way, dotaipin also has come in between. Dotaipin as an antidepressant, it's good. But beyond that, the other side effects. If SSRIs and then SNRIs were not there, I think we all would have been prescribing dotaipin and then imipramine. There is no choice at all. But the acceptance from the patients would have been very, very less. But that's a good drug.
Hello.
Somebody would like to?
Hello. Can I ask you a small question?
Yes, sir. Please, sir. You're most welcome, sir.
As an adjuvant, as a little motivating agent, can you think of an addition of, in certain instances, modafinil?
Yes, sir. That's perfectly, sir. That's a very right question, sir. But as I was telling, sir, from the beginning, this topic was mostly how do we choose an antidepressant to start with? What all we are talking about augmenting and then second drug, third drug at some point of time not showing enough response or very retarded. At that stage, straight away from day one, I will not prefer, sir. Some people may prefer, say, somebody asks in a retarded depression, what is your choice? My choice is still one of these drugs. Escitalopram, or maybe I write fluoxetine, but straight away modafinil as a single agent, I will not use as antidepressant in depression. As a second agent, if I have to use, I have to use two drugs, which I would refrain from for some time. Later, maybe I use, but not initially.
I said as an adjuvant only.
Yes, sir. Even that, let us say, sir. Not in the beginning.
Right. Okay. That's
you,
good.
sir. Thank you, sir.
Thank you.
So, thank you very much. And thank you very much. I think it's wonderful. And right, after seeing the last slide of today, I don't know, if I would like to take your opinion and then see that maybe for this one, this is the amount of burnout, and then this is the amount of depression in psychiatrists in North America. And maybe, see, psychiatrists will be about 1 lakh in North America, but it's only representative sample. We can't comment on anything. Maybe the next topic, can we do something completely different, something like which I did a few times, not like really know so much about it, but give a kind of an introduction and then sharing my views about counseling in Bhagavad Gita. If some of you agree to that, maybe do we do that? Or if somebody has an objection, we'll leave it at that and then we'll see tentatively the topic for the next session. Thank you. Thank you very much. Thank you all for your wonderful being here, present here. Actually, very, very lively discussion today. It's wonderful. Some of you even came live and talked. I think that is what we were trying to request also. All of you are experienced, more knowledge, more wisdom. I think some of these points are very well taken. Thank you very much. Thank you, sir. Thank you all. Good night.
Thank you. Thank you very much, sir.